Endocrinologist, and my interest is adolescents and young adults, and really how we help teach them how to manage their diabetes as they're getting older, and also help the parents and the families as they're working with kids in those age groups. So like I said, I just kind of have an outline to go through different things, but just to point out that, so our adolescent population is one of our highest risk populations with type 1 diabetes. They have more complications, so more hospitalizations and DKA, higher A1Cs than our other age groups. They also have more obstacles to their care, so if any of you have had adolescents at some point or remember being an adolescent, the challenges for them are that developmentally, many other things are at the top of their importance list. So they're more interested in their friends or the sports that they're doing or going off to college or who they're dating or what someone texted you during their visit than they really are about managing their diabetes, which is very developmentally appropriate, but also makes it difficult then to work with them to figure out how to motivate them to do the tasks that you want them to do. They're also going through many kind of developmental and transitions. So they may be leaving home for the first time, learning how to get prescriptions or get medications on their own, or learning just how to manage their diabetes separately from their parents. Additionally, an interest of mine is kind of how the brain develops and the thought process develops. And it's not until your mid-20s that you actually have complete development of your frontal lobe, which is responsible for being able to plan and make decisions, and a lot of skills that are really necessary to be successful with type 1 diabetes. So it's not really that our young adults are not trying, it's that their brains are not even really at the point to be able to accomplish all the tasks that they need. Additionally, one of my favorite studies is looking at risk assessment in adolescents and how long it takes them to be able to assess whether something's risky or not. And they compared adolescents to parents or adults and asked questions like, is it wise to swim with sharks? Is it wise to drink Drano? Would you set your hair on fire? And adolescents took twice as long, if not longer, than adults to decide whether or not those were smart decisions. And in addition to that, when they were looking at adolescents' brain activity during the questions, multiple areas were lighted up versus just focusing on the fact that there was a question at hand that they needed to answer, which I think is a nice way to descriptively see that adolescents really struggle with those day-to-day decisions that are required to be successful with type 1 diabetes. So for all of those reasons, they've become of real interest to me. The current models for addressing care in adolescents are typically looking at either a coordinator to help facilitate their care and kind of direct their care, a specialized clinic that really is just trying to get them from pediatric care to adult care, or education programs directed at specific age groups. I think there are many challenges with those different approaches. Most of those that have been able to show any differences have been done in a grant setting where there was actually additional funds to provide a coordinator or additional funds to have extra clinics and those types of things. Education also doesn't really work a great deal with this age group and is not necessarily the best way to really address it. So I think there are complications or challenges with the models that have been used. So I came to the Barbara Davis Center about a year and a half ago with my goal being to focus on a new clinical care approach for adolescents and young adults. So I came with that interest and really with the interest of focusing on behavioral and developmental tasks at each age group and to use those to kind of guide what we were going to do clinically. So I was looking for a way to, and if you have diabetes yourself, you know you spend a lot of quality time at the doctor already. And so my goal was to figure out a way to maximize the amount of time that our adolescents and young adults were already spending with us. So we asked them to have 3 or 4 appointments per year, which is a lot of time away from school, away from work, from families. And so I was trying to figure out a way to improve the clinical care that we offer through their regular appointments. And shared medical appointments are a model that have been used in other conditions or other types of medical arenas. So, for example, pregnancy and prenatal care started using shared medical appointments where multiple people would come at one time, would talk together about whatever the issue was, and then see the doctor kind of in rotation. And they found through that model was made out of necessity for we have to see a lot of patients and we don't have a lot of doctors. But what they found was that satisfaction was improved in patients, outcomes were improved in patients, but also provider satisfaction and efficiency was improved. That model since then been used in some adult populations for like type 2 diabetes. And so my thought was if we use that similar model with adolescents and young adults, not only would we maybe be able to get in some education and have them benefit from working with one another, but they would maybe feel more comfortable learning from their peers versus learning from us. So basically I started talking with people that have done shared medical appointment models for different reasons, and then took that to apply to different age groups. So we developed 3 different developmentally focused clinic approaches. One for middle school, one for high school, and then one for the beyond high school age group. And I kind of put specifics in here, but the general model is that we have all patients come at the same time. They spend time alone with myself or the nurse practitioner, whoever's working with us, to do physical exams at the beginning. And there have actually been studies to show that just spending time alone with the doctor and getting used to that as a pediatric patient will help you more successfully transfer to the adult medical world or adult providers. So that's kind of the first part. And then we spend time together as a group, the patients or kids with us and the parents together in their own group. And groups are facilitated by either one of our social workers or diabetes educators or nurses to kind of guide discussion. And I'll go through each individual clinic and kind of how they're different because they're all developmentally a little different. And then at the end, we go over kind of the game plan with the parent and the patient together with the provider. So that's kind of our general model. So for the middle school clinics, so the 6th, 7th, and 8th graders, we do more kind of structured skills, hands-on type learning for them. So for example, we rotate types of clinics every 3 months. So we've done one where we've gone outside and run obstacle courses, but we started by checking your blood sugar and talking about the last time that you had insulin, doing the obstacle course for a while, checking our blood sugars partway through, talking about how your blood sugar could be impacted by that exercise, and then finishing the obstacle course and going through the same thing at the end. And giving the kids kind of learning points or things that they tell their parents at the end of the appointment, what they learned about whatever they had done for the day. We're currently doing Jeopardy, which middle school kids really love. And so we're doing things like, what are ketones? What do you do if your blood sugar is high? What does insulin do? And what blows me away is that these kids do many of these tasks, but don't understand why, or even why we're asking them to do it. And so the things that they'll say in clinic are very surprising to me, and I don't think they would say if it wasn't in this type of format. Our next round is actually looking at our next 3 months. We're going to do more skills where we have patients that are on pumps talk about their pumps and kind of show others. Patients that are on injections talk about how they do that, and having us teach them those things. Again, because depending on the age that a kid is diagnosed with diabetes, their parents were likely taught a lot about diabetes management, but then they just kind of take it on tasks over time and never really learned why they have to do what they do, or even how insulin works or what your blood sugar really does in response to insulin. Many don't know. So we try to focus on those. At the end of the middle school group, we sit down and we try to use a lot of positive psychology and motivational interviewing, which I'll talk more about related to the larger study you referenced, to kind of guide what we're doing through clinic. And we end our clinic with talking about what do you do well, whether or not it's related to diabetes or not, and then how could you apply that to something that you do related to your diabetes, like one thing you want to work on. In the parent group, we focus on what's developmentally normal for your child being in middle school, because a lot of parents will contribute all behavior to diabetes, and the reason that they have disagreements about things related to diabetes, when in all honesty, many of it is just totally normal behavior for a middle schooler. So we'll talk about those things, and then how does diabetes play a role, and then how as a parent can you help your child through each of those things. And then the parents also do the same thing. What do you do well for your child that has diabetes, and then what could you do to be helpful for them? Not what should your child be doing for the next 3 months, but how you as a parent could actually help them through that process. So that's our middle school clinic. Our largest clinic, and the clinic we've done for about a year, is our high school clinic. So that's freshmen to seniors. And they all come again at the same time. We have the exams at the beginning, and then we really have them kind of drive the discussion. So the high school one is definitely more patient driven. So we have different approaches to get them to kind of talk about things that they're interested in. We've done questions into like a bucket, and then they all pull them out and individually answer the questions amongst themselves. And again, the facilitator and then myself and the other provider are there to discuss questions with them, but our goal is for them to kind of teach one another. What we found is that they much prefer to be able to talk about things that they're worried about or think about than us driving education at them. They kind of check out if they think that we're kind of directing that. And so the topics that we typically discuss with adolescents are driving with diabetes, sports and diabetes, how you talk to your coaches about that, how you're an advocate for yourself at school, if you tell your teachers, if you tell your friends. Many, depending on their time of diagnosis, have chosen not to tell others or don't share with friends or don't do any diabetes tasks around friends, so we talk about those things. We talk about sex and drinking safely with diabetes, how you would do that, drugs, and then of course we talk also about research and management of their diabetes, pumps and different types of technology, and then often end up going through those kind of with a group with one another, talking about what they've done. And we really kind of have them drive it, but we kind of tackle the same topics every time. And then the high school group ends very similarly with them talking about something they do well and that they're proud about, and then something that they want to focus on, for their diabetes. And then we have a beyond high school group where it's 18 and over. So for many of these are kind of 18 to 19-year-olds that are just leaving the house and possibly taking over diabetes for the first time. So for those groups, we really focus on logistics, kind of problem solving, because for many of them, it's 2 o'clock in the morning, I really don't have any insulin, I don't know what to do next, and maybe I'm sick. What do you actually do? So we kind of go through step by step how to do that. How do you get prescriptions? How do you move to an adult doctor? And how do you even make that appointment? So it's really teaching them just skills to be able to manage diabetes separate from their parents. So we've done this for about a year, with our biggest groups being middle school and the high school. And I'm going to talk about the college age group and things that we're doing to address that kind of in a different manner. But what we found is that, and we're still collecting post data now, what we found is that patients really are satisfied and prefer this type of clinic method. So 90+% report that they would like to come again, that they would recommend it to others, that they feel more comfortable asking questions. They're coming to clinic more often, so they're coming every 3 months or so, when many of them before were coming maybe every 6 months and that type of thing. They're reporting feeling more comfortable in clinic just in general. And appreciating the fact that they can talk to other people that actually understand. The parents report the same thing, that they feel more comfortable coming to clinic, that they prefer being able to talk to parents, and that they're learning more through the appointments that way. We've also found that the duration of appointments, or the time for appointments, is pretty similar, sadly. Again, if you need to go to the doctor, you often end up waiting for quite a while, or you end up waiting for a nurse to come in and that type of thing. So the timing for us is pretty similar for group appointments, because you just have a doctor and nurse dedicated to those in the group for that time period. We've also found that our depression rates are disturbingly high in all of our patients that have diabetes, whether or not they're in our control group or in our intervention group. So I'm actually doing other studies looking more kind of at depression just in adolescents and young adults with type 1 diabetes, which we know is higher than the general population, but we're looking at how could we address it from a clinical standpoint a little bit better. And my next steps for those projects, we're going to do, and I'm talking with different funders now about kind of what it will look like, but we're going to take a randomized controlled trial approach and separate patients into being in our group clinics or not being in them, and then seeing if what their outcomes are related to adherence and satisfaction and A1Cs and that type of thing, and then cross over and see if our outcomes hold true, or if they change if you change which intervention arm you're in. So those are kind of the next steps as far as for our group clinics. And that's most of the information that I have kind of on the first page or so. We've had we've had 100 or so high school kids participate, and then we've had close to 50 to 60 middle school kids. And then our biggest challenge, which is across the board for all pediatric endocrinologists or just endocrinologists in general, is that 18 to about 25-year-olds. They're kind of lost from diabetes care, and they often show up later than with more complications. In the past, I think part of that has been insurance. I'm really hoping that maybe that's improving with changes in our healthcare. However, that population still has so many things that are at the top of their agenda that don't include diabetes. So it's college, it's moving away from home, it's figuring out your job, and all of those things that are really developmentally appropriate for them that weigh higher than their diabetes until their late 20s or 30s. And then for many of them, they've already had a lot of complications in that time period. So I've been trying to think of a way, a different approach to really reach college age or 18 plus year olds. And I actually started talking with the chancellor at the University of Colorado and then focusing on the Denver campus about maybe there was a way to use telehealth options to really reach students that are on college campuses. Because for many of them, it's the problem with their schedules being variable, coming to normal clinic hours is rough, as well as just fitting it in. So we're actually starting a pilot we're starting it through the summer, and then we'll begin in this next school year, where we're working with students that have type 1 diabetes on the campus and seeing them by telemedicine. So, and it's not even going to be where they have to go to like the student health center to do the visit. They're able to log in from their phone, from their iPad, from their laptop, wherever they may be, their dorm room or home or anywhere on campus. And we're going to use our group clinic formats, so the team clinic formats that we have, and I've actually piloted it through our team clinics. Basically, it looks like the Brady Bunch, which now I realize younger kids don't even know what the Brady Bunch is. But it's the Brady Bunch idea. So they all show up in little squares on the screen with our facilitator in the middle. And so we kind of have a group appointment just through sitting on your sofa with your iPad in front of you. And then we have a time where they talk with me individually, again, just through their iPad or laptop or whatever, to do kind of the follow-up part of their visit and their plans for next steps and that type of thing. So I'm really excited because I think even kids that do continue to have care through college, or young adults that do have care through college, many of them it's less frequent or it's very intermittent, and they also maybe don't even know who to call with questions and that type of thing. So my hope is if we can find a model that will work well for them to be connected while on college campuses, we can help them through that. I also really feel strongly that behavioral and mental health is kind of more of a concern for that young adult population in general, and so I'm working with the chancellor there to see if we have a model that works, can we use it to provide psychology and psychiatry and mental health support to the population on campus in general. So those are kind of my big projects. And then to talk about the FLEX study, so that's the one that was referenced on the UC Denver, or the University of Denver website. So it's the Flexible Lifestyles Empowering Change, or FLEX. And so it's a multi-site study through University of North Carolina, Cincinnati, and then we're the third site. So there are psychologists at Cincinnati that have developed a model, and it's looking at 13 to 16-year-olds with A1Cs 8 to 13. And it's saying if we take behavioral approaches and apply them really intensely in this age group, can we change outcomes over time? So it's based on motivational interviewing, which is a technique to really get to understand what is it that's driving your behaviors, and then how do we impact that, as well as teaching problem-solving skills for both the parents as well as the kids. So it's really driven by a coach, not so much a doctor. And so we have two coaches at Denver that will be working really closely with parents and families, or with kids and families, to really address the obstacles that they're encountering related to their diabetes care. So visits will be pretty intense at the beginning. They'll have 4 visits over the first 3 months. And then it kind of tapers off depending on how their A1C goes during that first 3 months. So they'll either be in contact with the coach just as frequently, or it may space out to see if we can say, okay, you can intervene this much intensely and actually cause, a positive change over time. And then you can kind of taper off and that positive change will continue. Or you still need to be in close contact with patients and families that are struggling to help them through those time periods. So it's neat. We all got together a couple of weeks ago to really practice the model and kind of go through it. And the coaches are really amazing people who are going to really be driving the change in parents and patients. So we're going to have the majority of the patients, but then there are also going to be some through Cincinnati, and then the University of North Carolina is really just driving kind of the development and direction of the clinic. So that's the FLEX study. And I'm trying to think if there was anything. The only other things that I was going to mention that I'm looking at in adolescents, disordered eating behaviors are becoming, or like diabulimia, if you've ever heard of those, they're becoming more and more of an interest in diabetes, because it's beginning to be realized that diabetes is a really challenging disease to manage without having food-related issues, and that develops quite young. And that actually, a third, depending on the studies, up to 10% in boys, and then even a third in girls will have disordered eating behaviors during their adolescent years with type 1 diabetes. So I actually started working with the Helmsley Trust, which is a large national group that funds a lot of diabetes research, and then a couple of advocacy groups looking at disordered eating behaviors in diabetes. And we're going to look specifically, how can we help providers and clinics be aware of it and begin to recognize it, and then is there a way for us to help improve screening and improve diagnosis, and whether or not what treatments kind of come from that. And then the last thing, like I mentioned, focusing on depression. So it's recommended by the ADA to do depression screenings every year, or mental health screenings every year, because we know depression rates can be higher in those with type 1 diabetes. And if it's there, then that leads to more complications. So we're actually doing a study looking at, can we screen for depression and give resources, and is there follow-up from parents and families? Are they able to navigate the mental health system to find resources, either psychologists or psychiatrists, to really address concerns? And so that's one of the studies that we're getting started in the next couple of weeks, to look at that and really look at barriers to being able to address mental health challenges in adolescents and young adults. So that's pretty much it.
I know you obviously have privacy issues with the medical aspects.
Yeah.
But do you record any of the group sessions you have and put it out on the web?
Yeah, that's a great question. In fact, because we're starting to talk more about something like that would be really important, because there's so much to be learned from what they share amongst one another. But what we're going to do next is really get more descriptive data, or more descriptive information from both parents and patients, because they give us a lot of feedback that I think would be really beneficial to be able to teach others. So we're starting over the next couple of weeks to do that. For example, I had a parent a couple of weeks ago that said, I just have to thank you. I don't know if it's actually going to impact his A1C over, the next little bit, but we fight less about diabetes. He's more excited to, he actually is fine coming to appointments, and feels more comfortable talking about diabetes with people in general, which I think are huge milestones for, an adolescent to be able to accomplish. And there's many situations like that. So we're trying to actually start documenting those so that we can be able to put it together for other people to see.
Sort of follow-on question to that. Are everybody that you see in those sessions, are they Barbara Davis patients, or if they're non-Barbara Davis, can they attend?
That's a great question. And I've actually had someone else ask that before. As far as wanting to come, because I've had kids that have gone, can I just come back next week to be able to talk and not have it really be an appointment? So we do things like that. And as long as they would we have privacy things that we discuss at the beginning to say that you need to respect everyone else. And as long as they would do that, it wouldn't really matter if they were receiving care elsewhere or not. to be able to participate.
Does ADA or JDRF, do they publicize the sessions that you're having?
No, and they don't. But we've just, in the last, like we put it into the news note sessions that kind of go through the Barbara Davis Center. I've recently talked with some people that do kind of the publicity type things on campus to talk about that a little bit more. And today I actually had a conversation with the board of directors for the Endocrine Society because they had heard about the groups and were wanting to learn more so that they could help kind of promote the model or to be able to describe it a little bit better. So, but it's great because I think one of the things that I was hoping to be able to target is that kids will always talk about diabetes camp and how that was the one time that they felt really positive about whatever, and they benefit so much from being around others. So we were trying to figure out a way to replicate that on a small scale just through the clinic and the time that they spend with us. And I think many of them actually get that. I didn't think a support group or that type of thing model worked because they already spend so much time with us, and really for them, they just want to be like their friends doing everything else. But there was a good way to be able to say we can address your medical needs, but also provide that extra support and learning amongst your peers at different levels. So.